guys could kindly fill in the feedback. It really matters. It helps us determine what changes we need to make this session as good as possible for you guys. Okay. Um, so these are some of the descriptors for the 2B marking paper. So clinical safety and management, as long as you aren't saying anything silly, you're being safe and making logical suggestions, you should be fine during the 2B examination. Um, there is going to be some information with regards to management that you are going to be tested on. And obviously, if you can demonstrate some knowledge beyond the core curriculum, often this is picked up during MDMs or different subspecialties that would uh, obviously raise your mark from just a 6 to maybe a 7, even 7.5, which will make it easier for you to pass overall. So I'm going to be concentrating primarily on, I expect you guys to pick up the diagnosis as well. And if you don't know what it is, what I'm looking for is how are you guys then moving forward in terms of where you think the management for this should go. Do you think certain lesion is benign? Do you think it's malignant? What to do if you think it's malignant, what to do if you think it's benign, and what to do if you're unsure. These are the kind of things that I'm looking for. And then if you can elaborate sometimes a bit more on a certain case as to so for instance, if you say it's this or more likely this than that, then you have to tell me why you think that is. That will help as an examiner for me to think, yeah, okay, this person knows what they're talking about. We know that they're safe and they seem to have made a logical uh, uh, management plan for the particular patient. In with regards to radiology, of course, first of all, and then also the broader management of the patient. Okay, so um, this is the structure, concluding statement. After you've said all the positive findings, what do you think it is, what your differential is, and what the management is, what I've just basically described, and how are we going to structure it? What do you refer? What is the referring? So inform the clinical team of an urgent emergent findings, any basic tests that need to be done, any immediate treatment that needs to be done. Again, entirely dependent on what you see on the case. What do you need to do as a radiologist? Any other further imaging or timeframes or any other intervention that we can provide to help aid the diagnosis or provide treatment? And what do other people need to do? Does this need to be discussed in an MDT or not? Does this essentially? So that's roughly what we're looking for. Obviously, every candidate has their own way of presenting things, but if you can cover these basic things, that would be great. Okay. So we're going to go over case 1 first. So I'm going to bring that up 1 second. So is the first candidate ready?
Hello, sir. I'm candidate 1.
Hello, candidate 1. So the first case that I'm going to put up is going to be a 50-year-old person who was involved in an RTC and had a cardiac arrest. Okay. Um, so I'm just going to put the case up. I will scroll for you. I think it would be easier that way.
Sure,
Okay.
sir. Sure, sir. Thank you so much.
So this is case 1. Can you see the picture?
I can, sir. Thank you.
Okay, I'm going to scroll through it and you can talk whenever you feel ready
So I've
to.
been provided with CT brain axial images of a 50-year-old male patient who has been who had suffered a cardiac arrest. In my first scroll from caudal to cranial direction, I could appreciate there was relative effacement of the sulci vision, and there was a relative homogeneous appearance to the whole of the supratentorial cerebral. I could not appreciate any significant area of intra-axial bleed. Ventricles appear normal. There is no crowding at foramen magnum. I'm looking at the review areas as well, and the vessels now. The vessels bilaterally and anterior and posterior circulation appear homogeneously hypertense. That can be because of relative homogeneous rest of the parenchyma and can be relative in appearance. Considering the patient suffered a cardiac arrest and is in critical care, and keeping in view these findings, this may be because of diffuse cerebral edema. I would immediately contact the emergency department and discuss the findings of diffuse cerebral edema with them, and the patient needs an emergency I would immediately ask them to get an MRI done to look for diffusion restriction and gyral edema. This is a critical finding, and patient needs to be intubated immediately and taken. The airway, breathing, and circulation should be immediately taken care of.
Okay. So so can you just summarize what your diagnosis is for this?
So there's diffuse cerebral edema. Considering the patient has sudden cardiac arrest, it can be hypoxic ischemic insult, and patient um, hypoxic ischemic cerebral injury. The patient might be suffering from hypoxic ischemic insult.
So, okay. So, what do you think the outcome is going to be for this patient
It,
if your
the,
diagnosis is correct?
so, considering that the patient has got a diffuse cerebral edema but no transtentorial herniation and no in the patient has got a relatively poor prognosis, but if uh,
Okay, that's
clinic,
fine. That's
yeah,
fine. A relatively poor prognosis. That's all. I just wanted to ask what you think the
yeah,
outcome is going to be. So, very well done. That was a very well presented case. You picked up on all the findings. You tried to look for some of the important things. For instance, you mentioned that there's loss of sulcal space, which is suggestive of cerebral edema. You tried to look for the vessels to see if they were hyperdense, either a thrombus or you didn't mention it, but like you basically said pseudo subarachnoid hemorrhage, which is what you get in where the vessels appear denser than they are, and that's normally because of you get edema everywhere, and it gives the impression that they are dense, but they're not. It's just something that happens due to cerebral edema. You can get partial volume resulting in hyperdense vessels, and you look for cerebellar herniation, foramen magnum crowding, all of these things you looked for. So it was very well done. You picked up on the diagnosis. So the only thing I would say is if you can during actually in fact let me put up the presentation. Let me just change it to that 1 second. Let me know if you can see the presentation or not when it comes up. We'll go over the slides very quickly, and then we'll do the next case after that.
sure, so thank you.
So can you see the presentation up on the screen?
Yes, sir, we can.
So, okay, so you mentioned it was an urgent finding. Perfect. That's what we need. It needs something, but just remember, if you can see the changes on the CT scan, it's a poor prognostic indicator. It can take up to 24 hours for that stuff to appear, but if it's taken less than that, damage has developed very quickly, and usually the prognosis is uh, very poor. Initial CT can be normal, and obviously you picked up on the clinical history of, this being a cardiac arrest. They tried resuscitation and hypoxic brain injury, but if the CT initially looks normal, but the history is suggestive, it is not unreasonable to get an MRI scan done, because the MRI scan, the flare sequences, even up to the first within the first 2 hours, you can start getting changes in the brain suggestive of hypoxic brain injury. But this patient ended up on ICU. This is where most of them normally end up, and all we can really do is have supportive care, maintain fluid, avoid hypothermia, because that can cause further edema and cell death, and medication to prevent further convulsions, and hope for the best. We can do short interval imaging and to make sure that more damage isn't developing. But yeah, very well done. Picked up on all the positive findings. All I would suggest is just you didn't mention pseudo subarachnoid hemorrhage by name, but you looked for it, so that's fine, and you were safe throughout the entire thing. So I'm happy with that. We're going to move on to the next case. So very well done. Just remember that these things. So if I ask you questions about do you think it has a good prognosis, you just need to say, yeah, no, it's a poor prognosis. And if you can, it's a bit of more information, we're looking for stuff beyond the core curriculum. If you can see changes on the CT scan, it's usually already quite late in the game. Does that make sense?
Right, sir. Right, sir.
So just a
Totally.
bit
Thank
more
you.
confidence, just a bit more confidence. Um, one of the point you mentioned that it may represent cerebral edema. If you can't see the sulcal spaces, particularly at the vertex, that means there is cerebral edema, especially in this clinical context. So just say it confidently. You know it is. Just be more confident with it, okay?
Right, sir.
So
Thank you.
so well done. That was very impressive. We're gonna move on to the next case, okay? So I'm gonna bring that up 1 second. Can you see the screen?
Yes, sir, I can. Thank you.
Okay, so this is a patient who presented with left-sided conductive hearing loss.
Right, sir. Thank you. I've been provided with axial sequences of in bone window of base of the skull. I'll take a moment. Bilateral mastoid ear cells are well pneumatized. I could not appreciate any significant soft tissue density on within either of the external auditory canal. I can well visualize the ossicles on the left side since the patient is having left-sided conductive hearing loss. I'm focusing initially more on the left side. Um, so the images are not scrolling now.
No, this is the slide I want you to concentrate on.
Oh, okay, okay.
Okay, so here you go. Gonna leave it there. What do you see?
So there is on this specific slice, I can appreciate a linear distance between the left-sided ossicles named incus, malleus and incus. This may, I would start with the contralateral side on the right side to see if it's any artifact or again on these images I could not see any the disarticulation of the ossicles on the right side. So this may represent
So the right side is normal.
uh, yeah, the ossicles on the left side appear have some gap in between them. So I like to see this on orthogonal views as well, like coronal if available.
So we haven't got coronal images. We've just got these.
Okay. So I'm trying to evaluate. I'm trying to assess the
Okay,
origin
I'm
of
gonna
the
ask you a couple of I'm gonna ask you a couple of things, okay? So what is this thin line that you can see? This one here.
tympanic membrane.
Okay. And what's this coming off the tympanic membrane?
The ossicles, this handle of the malleus.
Yeah, so the malleus comes off the goes and attaches to the tympanic membrane, okay? So
Yeah.
this area that looks kind of spongy and sclerotic at the same time, if you compare it to the other side, put the other side next to it. So you can see on the other side, there's not this kind of spongy appearance of the bone. Yeah,
Yes,
this is
sir.
normal.
Totally.
Here you got this spongy kind of almost expansile appearance of the bone. Now, if you look at the normal side on the right, okay, you can see a bit of bone come off, and then it joins another bit of bone here, and then travels down into this region. Okay, so this limb coming off, this is the incus, limb of the incus, and then where it joins is this
Stapes,
stapes, and then that goes into the oval window.
oval window.
Okay, so here, if you look at it, What do you see?
So this is the sclerosis of the oval window, autosclerosis, and
Yes, yes, that's right. Yeah, well done. It's not an easy case, it's not a straightforward case, and it's not very common. But you did so well in the previous case. I thought I'd give you something a bit harder because you made it look too easy previously. But yes, it's autosclerosis. And this one, sorry, I'm just going to bring up. So first of all, tell me more about autosclerosis. What do you know? Do you think this is an urgent finding? Do you think this is something
so it's
that can
more
wait?
common in
And who do we
females, happens in middle-aged females, and it's not an urgent finding. And the patient needs to be referred to the ENT for further evaluation. They might be trying to. They might offer some conservative management. If not possible, they might be doing surgical. They might be taking up surgical option to do surgical option to resolve this issue for her.
So do you know what kind of surgical options? What do they normally do?
No, I'm sorry, I'm not aware of that.
So they normally do a stapedectomy and put a prosthesis in. So they
Right,
remove that part of the ear and then do a remove part of the stapes and they put a prosthesis essentially to make sure that
right,
the conductive loop is formed. But this is just a bit of information beyond the curriculum. This is what we're talking about, to get the higher marks. So if you get a case like this, normally you're doing pretty well. They're going to give you something harder, and you already know quite a bit more than what other candidates will know about what this is and whether this is something that needs to be done urgently. So very well done. I mean, you picked up on the abnormality. So I'm really happy with that. I'm just going to bring up the slide quickly. Okay, 1 second. Um, to give you another example of this as well.
So, sir,
Again,
this is definitely not an urgent finding, right?
yes, it's not an urgent finding.
And
You're
do they
right. It's
directly
not
go
an
for a stapedectomy, or do
no.
they?
So you hit all the you if it's a surgical management, then that's what they'll do. But most of the
Right,
time, they try and manage it conservatively.
right,
You also
right,
have to consider the age of the patient, whether the patient is fit enough to have surgery, whether their symptoms can be managed conservatively or not. Do you know, all of these things need to be considered, but ENT referral usually managed conservatively. If it's not helping, then they might consider surgery, which would involve so and so. That's how
right,
you would say it in the presentation, okay?
right, sir. Right, sir. Thank you.
So this is the one that the stapedial one is a fenestral one, the most common one. This is the one that's usually associated with conductive hearing loss. The cochlear one, retrofren, which I'll show an example of next, is usually more sensory neural, and then unilateral, bilateral majority of the cases. This one was a unilateral case. One of the reasons why I showed this is also because it was so obvious. Usually these are very subtle, but this one is the largest one I've ever seen. So I thought I'd see it and you picked up on it, so that's good. This is an example of a cochlear one. So you got the cochlear rings over
Oh,
here on either side, and you can see this. It's called we call it otosclerosis, but otospongiosis is, I think, is what the term people are trying to use it more because it's more a spongy appearance than a
understand.
sclerotic appearance, if that makes sense.
Right,
So
right,
this is
sir.
the one around the cochlea,
Oh,
okay?
yeah.
So this is the other one, which is a bit higher up around the cochlea. So just if you do ever get a case, you've seen it, so you won't, uh, you know,
Perfect.
um,
Yeah.
all right. So we're going to do the next case now. Case 3, 1 second. Can you see the screen?
Yes, sir. I can. Thank you.
Okay. Just gonna scroll through. Okay, just whenever you need to speak, you start speaking. You don't need
Been
a history for this one.
Okay, sir. So I've been
Headache.
provided with CT brain axial slices. In my first role, I could appreciate a mixed NC altered signal, intra-axial, supratentorial, relatively well-defined brown configuration lesion on the right side in the right higher frontal region with a rim of significant surrounding paralesional edema. It has a central hypodense area, likely necrosis, with an eccentric medially placed hyperdense, likely hemorrhagic focus. I'll try to go through the images again to look if it's the only one, or I would try to look for any multiple lesions as well. With this lesion, I could not appreciate any significant intraventricular hemorrhage or subarachnoid hemorrhage. There was no crowding at the foramen magnum. There is no transtentorial herniation, no midline shift. Um, so in there is a suggestion of a small subarachnoid hemorrhage along this lesion as well, anteriorly probably, but I would confirm it on the other orthogonal views as well. If considering this is the only image I have, that's a non-contrast CT brain. I do not have the history as well. My top differentials, if it's an elderly male patient, it can be a metastatic deposit with a hemorrhage in it, hemorrhagic metastatic deposit that can come from RCC, or if it's a female patient, it can be a breast malignancy met, or it can be a lung malignancy or melanoma met as well. It can be my other differential would be glioblastoma as well, but it has got a relatively well-defined margins, non-infiltrative. So glioblastoma is down my differentials. I'll immediately pick up the phone and inform the referring physician. The patient should be undergoing MRI post-contrast for further characterization. And if there's a known malignancy, the patient should be restaged according to this lesion.
Okay. If it's suspected to be metastatic, then what further imaging would you do?
If it's metastatic, I would check through the previous records if the patient is a known patient has got a known primary or not, because the patient needs to be checked for lung primary tumor. If the patient is female, the breast ultrasound should be done to rule out breast malignancy. Also, RCC also gives hemorrhagic mets. Also, melanoma mets are hemorrhagic.
But with any suspected metastases, I'm saying if you suspect that these intracranial lesions are metastatic, what further imaging would you do?
Uh, PET CT.
Okay.
If
What's more
I
basic
don't know
common?
the primary, basically, if we are
Yeah, I mean, what
suspecting
I'm
the,
saying is this is the first case presentation. You've seen a lesion
yeah.
in the skull. Okay, let's just say the patient's more than 40. Okay, and we are, and initially you mentioned correctly we would do an MRI, and let's just say on the MRI they've seen more than one lesion. Okay,
So
which would
CT
be
chest, abdomen, and pelvis with contrast.
yes. Okay, excellent. That's what I'm looking for. That's the answer I'm looking for.
Okay.
So with any suspected metastatic, uh, you know, intracranial lesions or any metastatic disease, the first thing is a tap. Okay, when it
Yeah.
comes to, I guess neck cancers is an exception, but we can talk about that later. But when you see this CT thorax abdo-pelvis, we need to do an MDM discussion in a neuro-oncology MDT. And obviously, this is an urgent finding. So you got all of that right. You're absolutely right. And very well done on the different types of hemorrhagic metastases. So I like to use mnemonics for stuff like this. My personal favorite for hemorrhagic metastases is MRCTBB. I don't know if you guys have heard of it. M is melanoma, R is RCC, which you mentioned as well.
C,
Uh,
C for choriocarcinoma, T for thyroid, and B
yes,
for breast
and bronchogenic. So
and
those are
bronch.
so MRCTBB is a good, all of these are kind of like radiology terms. So if it helps you, then that's good. And if you can mention it in exam when you get a chance, that would be smashing. Okay. So very well done. Yeah, that was really good. Didn't really miss anything. Really happy with that. Just gonna bring up the presentation quickly. So you mentioned it was an urgent finding, suggest whether likely primary or mets and what to do in each case. That was fine. What further imaging to recommend and why? We've discussed that briefly. Neuro-oncology, MDT. Neurosurgery will likely do a biopsy first. If, for instance, if it's a suspected, if we can't find any other lesions. okay,
Mm.
and you've done a CT tap and it's come back as negative, you'd still do a biopsy just to be 100% sure, and then likely resection based on that. Okay.
Right, sir.
So,
So, sir, in this typical scenario, there won't be any role for PET CT if
PET
we are
CT.
unsure whether it's a primary or
So
secondary
let's
or.
just say they've done a biopsy and it's not a primary, and we can't find anything on the
Then,
initial CT scan. Then you would do
right,
a PET CT.
right, 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 right.
PET CT is a study that we normally do when we can't find something that we're suspecting. Does that make sense? It's a
Totally, sir.
hunting expeditions. It's a way of finding stuff out when you can't find it through normal means, like a CT tap, which we do for staging. Then you'd consider PET CT.
Right,
Okay.
sir. Right, sir. Thank you so much.
Um, so next for case 4. Let's see. Okay, so I'm gonna show you a few images for this one, and then I want you to try and tell me what's going on. Okay, so remember, we're also thinking about the way you think in the exam. So this is, can you see the images?
Yes, sir, I can. Ultrasound images.
Okay, so the ultrasound images that you can see on the right hand side, okay,
Yes,
and
sir.
the images that you can see on the left hand side, these are approximately 3 months apart. Okay.
Oh, okay. The one which has written thyroid left on it, it's the first image, and then the other one on the other side is 3 months apart.
So the one on the right hand, sorry, the one on the left hand side of the screen is the latest, the one that says thyroid
Is-
left is the
Okay.
latest scan.
Right.
And then the one
Right.
on the right hand side that just says thyroid is the
Yeah.
one
Okay.
that's the oldest scan. Okay, so the
Okay.
newest
Fine.
scan on the
Okay.
left hand side and the oldest scan on the right hand side. Okay,
Right. Right,
so
sir.
actually you only need these 2 slides. You don't need the other slides. So I'm going to see what you think is going on, and then you can talk me through it, okay? And what we should do next. So
Right, sir.
initially, when the patient had this scan, they had, this is the left lobe of the thyroid where the cursor is moving, okay?
Yes, sir.
And then 3 months later, they had a follow-up imaging in which the left lobe of the thyroid has decreased in size, but the right lobe of the thyroid is now demonstrating a more heterogeneous echo texture and has increased in size.
Yes, sir.
So what do you think is going on?
So in the previous images, I could appreciate that the right one was relatively homogeneous at that time, while only there was a unilateral pathology on the left side, while in the later 3 months apart images, whole of the thyroid gland predominantly had a heterogeneous ecotexture bilaterally in both lobes. However, the size of the left-sided lobe, which was previously predominantly involved, has also shrunken in size. I cannot appreciate any typical well-demarcated solid or cystic lesion in it. However, whole of the parenchyma has got a pseudo-nodular appearance with few echogenic horizontal septations running through it. The smaller size of the left thyroid lobe as compared to the previous one indicates towards the uh, fact that there might be some chronic process that has led to the fibrosis of the left-sided lobe. However, the process has also significantly affected the right-sided lobe. And in my actual practice, I would also try to establish a vascularity of the parenchyma. I would look for any cervical lymphadenopathy. I would check if the patient had undergone any thyroid function tests or any antibodies for to rule out any thyroiditis. I will in my referral, I would inform about all these findings. And if the TFTs or antithyroid, antiglobulin have not been done before, I would suggest to get these done to establish a diagnosis for maybe a subacute or chronic thyroiditis, because that may present initially with um active hyperfunctioning thyroid gland, and later on it can lead to fibrosis of the parenchyma.
Okay, so your primary diagnosis in this case you think is
subacute thyroiditis, subacute or leading to chronic.
Okay, excellent. And do you think this is well, you mentioned that you don't think this is an urgent finding, do you?
No. I'll just put these things in the report. I'll put an alert to it so that the referring physician gets a note of that. He needs to get a TFT test and anti-thyroid globulin antibody testing done for the patient.
Excellent, amazing. You're absolutely right. So this is a case of thyroiditis. So I'll just briefly expand on the case. So this, when the patient initially presented with some swelling on the leg, they noticed a lump on their neck and they referred for an ultrasound. And this is what was initially seen by one of my colleagues, this mass, and they thought that this was a malignant thyroid lesion, and they decided to do an FNA on the lesion. And when the patient came in, unfortunately, the list was so full that the patient actually came in 3 months later. It wasn't something that we decided we were going to do it. They came in for that, and when we saw them the next time, the side that was affected had actually gone down in size, and the contralateral side demonstrated signs of thyroiditis or inflammation of the thyroid. So one thing to remember about any cancer is that increases in size, it never goes down in size. So anything that goes down in size is never going to be cancer. Okay.
Mm.
And in this case, it wasn't cancer because the left side had gone down in size
Right.
and the right side had become involved. So it has to be thyroiditis or some kind of inflammatory process. It can't be cancer.
Right, sir.
And all the lymph nodes. But yeah, perfect presentation. You hit all the important points. You demonstrated knowledge perfectly, and you picked up on the right diagnosis. So I'm very happy with that. It was very, very well done.
Thank you.
Okay. Uh, okay, we're gonna do one more case with you before we move on to the next candidate. Uh, yeah, so you mentioned all of these things. I'm just sorry, just moving on to the next case. So apologies if it's taking me time to switch between cases. I am doing my best, but I'm not used to this Cyrix software very well, which is what I'm using. But okay, can you see the images?
Yes, sir. The ultrasound images.
Yes, so this is an ultrasound scan of the neck, okay, in a patient who's noticed a lump in the throat, okay?
Right,
Or
sir.
they can see a lump. So I'm just gonna move down to the relevant bit that I want you to tell me about. So this is the left thyroid lobe. Okay, what do you see and are you worried?
Sir, there were multiple images, out of which in this image there is a well-defined, well-demarcated, smoothly marginated fluid containing predominantly cystic lesion in the left lobe of the thyroid gland. It has got few echogenic foci with posterior enhancement, giving a typical colloid appearance. Since I could not appreciate the rest of the thyroid lobe, so focusing only on this is
Yeah, just this, yeah.
yeah, this is a typical colloid nodule in the left lobe of the thyroid that is categorized as U2 category, and even this does not require any FNSC for further characterization. However, if the symptomatic or if it is increasing massively in size, giving symptoms to the patient or giving some cosmetic difference to the patient, then we can offer them an aspiration. But the fluid can reoccur if it's aspirated once, so this should be communicated to the patient that full time aspiration is not therapeutic treatment for this colloid. That is just for a temporary relief. This does not has got any malignant potential, so it does not even need a follow up.
Excellent. Yeah, absolutely right. Yes, this is a colloid cyst. You've got these posterior um, um, basically a comet tail artifact because they look like comet
Comment.
tails. This is colloid. This is a completely benign nodule when we leave it. And you're absolutely right. If the patient is symptomatic, we can offer some aspiration, but any cysts, they almost always fill up. Okay. It just depends on how quickly it fills up is entirely dependent on the patient. We can't really predict that. And the only way to really get rid of it filling back up is to have it surgically removed. But on the NHS, we don't offer it for benign lesions, which are U2. Okay, so
Yes, sir.
that's fine. That's absolutely perfect. What do you think about this one? This is on the right side. This is on the opposite side.
These are two separate liens, or these are
Yeah,
two
so this
separate
is
views of the same
separate
lien? No,
lesions.
no,
So
not
this,
the solid one. Solid one, it has got an excellent transverse and longitudinal dimension that are being shown.
yes, yeah. This is the
So,
long, this is the transverse.
yeah. So this is a predominantly solid, well-defined hypoechoic lien. In these specific images, I could not appreciate any significant punctate internal calcification. Some internal vascularity is appreciated. In my actual practice, I would also measure the lien and I would see if the lien has been previously scanned or not, and if there is any interval increase in size of the lien. With this lien, I would also like to scan the rest of the neck for any suspicious lymph nodes. Considering its solid nature, hypoechoic texture, and surrounding capsule, it's however, with no calcification, it's categorized as U3. U3, that subjects is to definitely a FNSC for further evaluation. I would raise an alert for this procedure, and I would inform the referring physician to book the patient further for FNSE for further diagnosis, as this can be a follicular adenoma or any malignancy further.
Amazing. Excellent. Yeah. Very, very impressed. Very, very few candidates I've ever tested seem to know the U thyroid classification, but you've nailed it. So very well done. Yeah, this is a U3, strictly indeterminate. So no one, so U1 no one uses. We don't use that classification. We just use U2, which is something we don't FNA, and U3 and above, all of those require an FNA. Okay,
Right,
so
sir.
let me just bring up the presentation to just highlight for all the candidates some of the things you're looking for when you're looking at thyroid nodules. Sorry, things everyone should know about thyroid nodules. And if you ever come across any patients, need to try and calm things down a little bit because a lot of the patients are quite anxious, quite nervous about nodules in the thyroid because they don't understand it. So just remember, thyroid nodules are very common, more common in females than men. We don't know exactly why they occur, but there's suspicion that they've been there since birth, and the vast majority are actually found incidentally when we're looking for other things. Um, Again, vast majority are also benign, even the ones that look suspicious. And the worst case scenario, even if it does turn out to be cancer, when we're doing an FNA, you are more likely to die of old age than thyroid cancer. Okay. The aggressive type, such as anaplastic, is very rare, and metastatic like PTC and more rarely medullary can also metastasize, but they are much, much rarer. That's why we do the FNA anyway to make sure. But you should always reassure patients that it's most likely going to be benign, and even if it is thyroid cancer and we are going to do a thyroidectomy or any kind of radioiodine therapy, it's quite well tested, has been happening for decades, and well established treatment for it. So the outcomes are usually pretty good. Okay, so thyroid nodules, you mentioned correctly, you said everything correctly, so I'm very impressed with that, that it's not an urgent finding. One thing I didn't ask, and I'll ask if you can answer that. If we see a thyroid nodule incidentally on a CT scan, do we need to do an ultrasound on it?
Sir, I would answer that according to what I have been practicing actually, and I would like to know your feedback regarding that, because if it's a large hypodense, hypoenhancing nodule with some calcifications on the CT, I do refer it for ultrasound assessment and U categorization further on the ultrasound assessment. But if it's a small nodule, less than 1.5 for maybe even 2 centimeters, then I just mentioned that in the report, and
Do you
that's it.
mention in the report not to follow it up if that happens, or do you just mention it in the
No,
report?
no, no. No, not for the follow-ups, but I do mention it in the reports. But if it's a suspicious looking nodule with calcification and size, a significant size, like 2 and above, then I ask them to get an ultrasound done and further assessment on ultrasound followed by FNA if required. But if it's small sub-centimeter or around 1 centimeter nodule, then I just mention that without suggesting anything.
Okay. So, yeah, this is interesting. So I'll tell you how to approach. So given that what we've just discussed about thyroid nodules, that the vast majority of them are benign, and even the ones that look iffy turn out to be benign. And if you do have thyroid cancer, you're more likely to die of old age and thyroid cancer. What do you think we should do with most of these?
So considering if they are benign,
But on a CT, you
mainly,
can't tell. What I'm saying, if you see it incidentally on a CT, given what we know about thyroid nodules, I'll just tell you what we do, okay?
yeah, yeah,
So how we practice this. So if you see it on a CT, the British Thyroid Association says unless the patient has a family history of thyroid cancer, has overtly malignant features, so it's invasive, it's invading other structures, and you've got lymphadenopathy around it, um, or there's suspicion of microcalcification, although how you can tell that on a CT is beyond me. Um, so unless there are suspicious features to the uh, nodule, we tend to not follow up with ultrasound. In fact, we put it in the report, especially if they haven't got a history, that it's a likely benign nodule that does not require further evaluation as per the British Thyroid Association guidelines. I would recommend just reading the BTA guidelines briefly. I'll see if I can find it at the end of the teaching session. I've got it somewhere. I should have put it in this thing. I haven't, unfortunately, but there's a little paragraph that summarizes it quite clearly. I'll find it at the end, okay? But
right. So
when you see thyroid nodules, you'll see a lot of the time you'll see in older patients, okay? Patients are in their 60s, 70s, 80s. You putting them, if they've got coarse calcification, I'm not worried about it. Coarse
mm,
calcification is actually not a bad sign. Coarse calcification is found more in benign nodules. You only
benign.
worry about microcalcification, which you can only really see on ultrasound. So most of the time, when you see a nodule on a CT, we tend to ignore it unless there's a history of thyroid cancer in the family. Um, so if there isn't anything that you're aware of, then just mention if there's a history, then do follow up ultrasound. Otherwise, leave alone as per the British Thyroid Association guidelines. Or if they've got aggressive features like lymphadenopathy
Mhm.
or invasion of surrounding structures. Okay.
Right, right, sir.
Uh, Other important red flags of thyroid nodules, it says here, taller than wide. So being tall as a thyroid nodule in the thyroid is a bad thing. So if a nodule, even if it's got all benign features, but it's taller than it is wider, then you need to FNA it. Okay. So say it's got
Mm,
peripheral vascularity, if it's got a hypoechoic rim, none of that matters. If it's taller than wide, FNA it. You'll find a lot of the times they turn out to be like Thigh 3 in terms of histology. Okay. Which would need a hemithyroidectomy. uh, you already mentioned it's a hypoechoic. If it's a hypoechoic nodule or it's a hyperechoic compared to the surrounding thyroid tissue, then that's a suspicious feature. Microcalcification, I've mentioned already. So with microcalcification, you don't get the common tail artifact that you do in colloid. They're also tiny dots, but you don't get much posterior acoustic shadowing. You tend to get more of that with coarse calcification, not micro. So if you get tiny echogenic foci without posterior acoustic shadowing, and without a comet tail artifact, then it's more likely to be microcalc, in which case you would need to do an FNA. If something has central vascularity, then that's also suspicious. Peripheral is fine. Um, and in terms of calcification, if the peripheral ring is discontinuous, that's more concerning than if it's a continuous ring. Less concerning features are practically the opposite of that. So if you've got in peripheral, if it's avascular, or peripheral continuous calcification, then that's a good sign. Spongiform appearance, it looks like a sponge. Coarse calcification, again, micro is the one we worry about, coarse, not too much. If it's wider than it's taller, and it's the same echogenicity as the surrounding thyroid tissue, all of these are benign features which we shouldn't worry about. U classification you mentioned is U1 to U5, from least to most likely malignant. Nodules classified as U3 and above need to be FNA'd, preferably in a cytology-supported clinic, which is what we do at my institution. Not everyone manages to get a cytology-supported clinic, but if you do, that's great because it increases the success rate in getting a positive result. from FNAs, and you don't need to bring the patient back in for multiple repeat FNAs. And
Right.
what does someone else need to do? U3 and above need a thyroid MDM discussion. You need two Thy2 results or two benign results in order to classify a nodule as benign. So the patient comes in, you suspect a lesion to be U3 or above, you bring them in for an FNA, you do an FNA, and the result comes back as Thy2, which is benign. That does not mean that the lesion is benign. You need two positive benign results in order to classify something as benign. Okay?
Okay.
This is all that
But
information. This is all the extra bit of information that if you get a chance to tell the examiner, that will get you higher marks. This is the bit that goes beyond the core bit. So this bit may demonstrate knowledge beyond the core curriculum. So if you've attended the FNAs and if you've been to the MDTs, you would know this information. I'm just concentrating a bit more on the thyroid is because something that I do quite commonly. Head and neck is something that I do quite commonly, and this is a head and neck session, so I'm concentrating on that. But just highlighting that for you, just thyroid classification is important. The colloid case is an actual case that came up in one of the one of the 2B examinations, and it was just to determine whether the candidates are familiar with what is a benign nodule and what isn't. You did extremely well in that, but I'm just highlighting it for the other uh, colleagues. So we'll go to
sorry,
the next.
excuse me.
Yeah,
Sorry. Can I ask a question, please?
sure.
For this U3 and above nodule, do we always refer the patient to the MDT discussion first and then FNAC, or what are we
So we
going
do
to do
both.
for the exam?
We send them to the FNA and they also get referred to the thyroid MDM because what we don't
Right,
want is the patient to be lost. They need to
right,
basically a thyroid MDM make sure that the patient comes under the purview of ENT, which are primarily responsible for thyroid nodules. Because a lot of the time we may get a GP referral or we get a referral from another physician which isn't an ENT. They'll come in for
right,
an ultrasound and we see a lesion. But if we see something that needs further imaging, then it needs to be brought to the attention of ENT. So you need a thyroid MDM discussion, which has ENT surgeons in it. And us as radiologists need to book, or I say
right,
book, we need to request and vet a FNA slot for the patient. So all of it
right,
is
right,
streamlined. Okay?
right. Thank you so much. Thank you so
No
much.
worries. Okay, next candidate, I'm just going to bring up the next case.
Okay. Assalamu alaikum.
Walaikum assalam. Let's bring up the next case. Who am second. Can you see the images?
Yes, CT scan.
Okay. So I'm just going to scroll through it.
Okay. So I am provided with the CT scan axial images post-contrast study. I am scrolling the images from top to bottom, and then I will convey my findings. So yes, so on these imaging, I can appreciate that there is a lobulated asymmetrical mass noted along the left side of the oropharynx with some cystic component in it. It is extending down to the glottic region as well. True vocal cords are unremarkable. Now I am going upside.
Okay,
Here
so
I can
you've picked up,
appreciate that
so
this is the
I'm just going
mass.
to stop you there for a second. So you picked up on the abnormality. So I'm going to give you a bit more context, okay? So the patient presented with 3-day history of developing left-sided sore throat, okay?
Okay.
And he's also been pyrexial. The inflammatory markers have been sent for, but they're still pending.
Okay.
So
So
based on the clinical findings or the clinical history,
yes.
you can just try and tell me what's going on as quickly as you can with the management plan.
Okay, so on these findings and the clinical information, these are peripherally enhancing lesions which are noted in the parapharyngeal region. These are likely parapharyngeal abscesses as well as tonsillar abscesses as well, which is involving the surrounding supraglottic region as well with edematous changes. There are also cervical prominent lymph nodes noted bilaterally, which are likely reactive. So there is asymmetrical narrowing is also noted. So as these are parapharyngeal abscesses, this is emergency because it has a very, they are very prone to extend into the mediastinum and extend in the surrounding structures as well. So it is an emergency. I will immediately convey my findings to the referring physician. And if these are aspiratable, then I will recommend to aspirate these uh, abscesses and send it for the culture sensitivity.
Excellent. Okay. Do you know the name for this?
Parapharyngeal abscesses?
Yeah. What else do we call it? I mean, it doesn't matter if you don't know. I'm just curious. Have you heard of Quincy?
I don't remember at this time.
Have you heard of something called Quincy?
Yes.
Okay, so this is it. So you've got the I'll show you. I'll scroll through the image. So yeah, you did everything right. You picked up on the abnormalities, and you mentioned that it was an emergency. You even mentioned the fact that this might need an FNA. This would normally be referred to the ENT urgently, and they might, if they can see it physically, if they can see an abscess, then they can FNA it to try and reduce the risk of it spreading.
Yeah.
And they would need IV antibiotics, obviously, for treatment as well, which would be better targeted once you've sent it for culture and sensitivity. Until then, broad spectrum antibiotics to cover. But yeah, so this bit here, so this is the right tonsil, this is the left tonsil. And as we come further down, then you can see in the parapharyngeal space, you've got these abscesses forming. So this
Yes.
is a peritonsillar abscess, also known as Quincy. But yeah, and it is a medical emergency. Basically, you've said everything there. I'm very happy with that. Excellent.
Thank
Well
you.
done. Uh, just gonna. Oh yeah, do you need to do any further imaging for this?
Sorry, sir?
Do you feel like you need to do any further imaging for this?
MRI can be a possibility to see the extent of these abscesses. Otherwise, on ultrasound, there is I don't think so. Ultrasound can help any further management. MRI would be helpful to see the extent of these abscesses.
Have you seen it done typically?
No.
So no, I mean, put MRI there because oftentimes candidates say maybe an MRI. But if you got inflammatory markers, you can see the collection clearly on a CT. Then what we tend to do is everything that you said, which is give them the antibiotic, send it from culture and sensitivity, ENT referral, possible aspiration. If the patient, despite all of this, then continues to deteriorate, then we do repeat CT first up. We don't do an MRI. It's a CT post contrast.
Okay.
So there's no need to do an ultrasound unless there's a collection large enough that you think, and you'd probably see it clinically as well, large enough that you think you can aspirate. But at that time, by that time, they probably need a surgical washout as opposed to an aspiration from radiology. Yeah.
All right.
So no
Okay.
ultrasound, no MRI. If the patient deteriorates, we can offer to do a CT. But other than that, everything you said is absolutely perfect. So well done. Okay. So we're gonna do the next case now. Case 7. Okay. So this is a patient who presented with headaches and seizures, okay?
Okay. So I with the axial image of the MRI post-contrast study. So here I can appreciate that in my first look that there are multiple vascular channels noted in the right side of the cerebral hemisphere at the vertex. And extending to the right side on the extending on the right side. There is no mesophatic seen, no hydrocephalus noted. So these are multiple enhancing vascular channels which are forming the nidus in the center and draining into the superior sagittal sinus. I'm looking at the vessels. So I am thinking of AV malformation, and I am looking and searching for its arterial supply, which is, I think, along the, as no vessels are seen on the dural surface, so it is not from the external carotid vessels. It is from the arterial connection is from the ACA and MCA, and venous drainage is through the superior sagittal sinus. So this is the case of AV malformation. I cannot appreciate any subarachnoid hemorrhage. There is no hematoma seen. So I will. It is an emergency. I will immediately convey my findings to the neurosurgeon and recommend the digital subtraction imaging of this patient for further evaluation.
Okay. What would the neurosurgeons like? What's the treatment for this?
The treatment of this is the embolization, coil embolization of the nidus.
Okay. What else?
As there is no cerebral edema and no cerebrospinal hemorrhage from this AV malformation, so sir, IR will help. I don't know further about the management.
Okay. I mean, that's fine. I just wanted to know. So the options for this, as you mentioned, is, there's an IR possibility as well, but it depends on the size. I'm not sure about the size. Unfortunately, Saqib isn't here, but I'll just give you a general broad overview. So there's a surgical possibility where the surgical resection is a possibility. One is IR, where they put in and they can use like glue and certain particles to try and block certain channels of the AVM. And then there's also they can give targeted radiation, especially to deeper and smaller AVMs. And sometimes they
Okay.
give that first in combination with surgical treatment to try and treat these. And this is something, and when, even when they do embolize them, which is what you mentioned, depending on the size, it may not be something that's resolved after the first go. It may be something
Okay.
that they need to do in different steps. But yes, you're absolutely right. This is something that um, is quite serious, urgently needs to be referred to the neurosurgeons, need to be discussed at the neurosurgical MDM, and then in combination with the neuro IRs can determine we need to do in terms of management,
Okay.
whether it's a combination of neuro IR and surgical, and vice versa. Okay.
Yes, sir.
So
Yes,
well
sir.
done. Yeah. You picked that one up. No issues whatsoever. Very well done. So we'll do the next one. Okay. So this is a 45-year-old female who presented with a headache.
Okay, sir.
Can you see the images?
Yes, CT scan. So I am provided with the CT
Oh,
scan,
sorry, one second.
uh,
It's the plain.
axial images,
Yeah, there we go. Let me start from the top.
non-contrast study. So on this non-contrast study, I am looking all the images and then I will tell my findings. So on these imaging findings, I can appreciate that ventricular and extraventricular spaces are slightly prominent, which could be age-related. There is enlarged and elongated occipital horn of left lateral ventricle. It could be a colpocephaly. I cannot appreciate any hemorrhage or calcification on this unenhanced scan. There is no cerebral edema noted, no hydrocephalus seen. There is a calcific speck noted in the right side. I'm looking at the thalamus. Thalamus appears slightly hypodense on this image, on this particular image. Cerebellum is normal. There is, I can appreciate there is dense transverse sinus on the right side. I have a suspicion of a dural sinus thrombosis, predominantly on the right side. However, I cannot appreciate any venous infarct or venous hemorrhage or hematoma. There is no tonsillar herniation seen.
Okay, the rest of the examination is unremarkable.
Unremarkable. Okay. So the striking finding I can appreciate is the right-sided hyperdense transverse sinus. It could be a durosinus thrombosis, and I will immediately convey my findings to the referring physician and recommend immediately MRI or MRV or CT venogram can be helpful if available.
Okay.
So I am provided with a CT scan, a post-contrast study. So I can appreciate, first I am looking at the durous sinuses due to a suspicion of sinus thrombosis. In my routine practice, I will do windowing to see the thrombosis and multiple corneal images and sagittal images as well. So this is a straight sinus, which is well opacified. And I can appreciate that bilateral transverse sinuses, transverse sinus on the right side is slightly hypoplastic. And yes, there is filling defect noted within that transverse on the right side. I will see the rest of the image, and this filling defect is seen extending to the sigmoid sinus as well. I will see the rest of the images to see its extent in the internal jugular vein, and I will see the rest of the images to again see the subarachnoid hemorrhage or any venous infarct or hematoma. Rest of the brain appears unremarkable. There is no abnormal meningeal enhancement, no hydrocephalus is seen. So this is the durosinus thrombosis. And I will convey my findings and correlate with the history of the patient. If the patient is dehydrated, if patient is on the on any drugs, if patient has any relevant history. This is all.
Okay. So urgent finding, and how would you manage? How are these managed?
Anticoagulation?
Okay. Do we do any follow-up imaging?
Yes, follow-up imaging should be performed to see the resolution of this thrombus.
Yes. Okay. Would you do, what kind of imaging are we talking about? What imaging?
MRI? Follow-up MRI? Sorry, sir. I could not understand the question.
So I'm asking, so you said follow-up imaging we would do. I'm just asking what kind of follow-up imaging are we thinking of doing?
MRI is the preferable because in MRI, the complication of the durosinus thrombosis can be perfectly observed, likely a venous infarct or other complications, and as well as the resolution of this sinus thrombus.
Okay. I mean, fair enough. I mean, you can justify that. You can also just do a CT post contrast because it's quicker, it's easier. If the patient's GCS isn't deteriorating, they're not deteriorating any further, the chances are the treatment's worked. And a quick, easy CT is enough. You don't really need an MRI. But yes,
Okay.
you could justify it the way you've said. Um, so I can't knock you for that. You're not wrong, but a CT is
Yes,
typically
sir.
what we do. Okay, okay.
Okay, all right, sir.
So well done. Yeah, very well done. That was well done. You got everything right. Basically, you picked up on the diagnosis. It wasn't the most easiest of finding, but you did pick up on it. And then once you picked up on it, you came up with the right diagnosis and you asked for the right investigations and you mentioned that it was urgent and you answered my questions about how you would treat it. So yeah, very well done. Excellent. Okay. So we're gonna
Thank you, sir.
move on to the next case. Uh, just bear with me. One second. I just want to bring up the right image for you. So this is a patient who was in an RTC, okay,
Okay. Okay.
and you know they've got multiple swellings around the brain. They've got some intracranial hemorrhage as well.
Okay.
But the on the CT neck, there was suspicion of maybe there was some injury to the arteries.
Okay. So,
So yeah, I'm gonna scroll through it slowly, and then you tell me what you see and uh, whether you think there is any injury, vascular injury.
okay. So I'm provided with the MRI image. This is the T1 weighted image. So on T1 weighted fat set image, in which I can appreciate that there are, sorry, it is the T2 weighted fat set image, in which I can appreciate that there is a crescent-shaped hyperintensity noted along the right side of the carotid artery, which is suggestive of dissection of right carotid artery. I can also appreciate some crescent hyperintensity along the right vertebral artery as well, which is also suggestive of vertebral artery dissection. There are high signal edema noted in along the left side of the face, which is seen extending into the parapharyngeal spaces. However, airway appears patent. So on these imaging findings, my diagnosis is the dissection of the internal vertebral artery and internal carotid artery and right vertebral artery. I will see the brain parenchyma immediately to see any infarction or any thrombosis or any embolic infarct, and convey my findings immediately to the referring physician because it is an emergency.
Okay,
Okay.
and how would this normally be managed, and would you do any follow-up imaging?
Yes, these patients should be followed up with MRI again to see the complications, because these are very prone to embolic infarcts and thrombi as well.
Okay, so normally you can see dissections on a CT. Normally, when we have a
Yes,
trauma
sir.
scan, somebody comes in, we're looking for vertebral artery dissections and we're looking for carotid artery dissections. And sometimes they're not so obvious, and there's a suspicion that there might be a dissection. Okay.
Yes.
In this case, there was suspicion, but it wasn't clear. So they did an MR, and even with the MR, with so much movement artifact as you saw on that imaging, there was a high signal, crescent-shaped signal around the areas of dissection, which you picked up beautifully. Very well done. Very happy with that. and you picked up both of them. This is what was presented in Saqib's presentation as well, just showing you different ways that well, the way the dissection forms, where you have a tear in the intima and then blood pooling and pulling that intima away from the wall, and that forms a true lumen and a false lumen, and that causes extension of the dissection. As you mentioned, this can cause embolic thrombi from the site of injury, and that can lead to multiple infarcts. So it is an emergency. So they need to treat it with usually anticoagulation.
Yes.
They obviously need to observe the patient neurologically, and if neurologically the patient starts to go down, then we need to do repeat imaging, okay, to look
Okay.
for the things that you mentioned. But follow-up is actually following treatment is a CTA in 3 to 6 months, because oftentimes these just resolve after coagulation treatment on their own. Okay.
Okay, sir. Okay.
Obviously, if there is a referral, if there is any deterioration in their neurological function, then they need a stroke team referral. Do they need a neurosurgical referral?
Um,
Usually not.
Stenting can be performed. Endovascular
Yeah.
stenting can be performed if there is any clinical suspicion of multiple infarcts, embolic infarcts.
Yeah. Okay. Yeah. All right. So that's that for dissections, which you picked up really well. I'm really impressed. We're gonna do the next case now, okay?
Yes, sir.
I think this is case number 10, so we're gonna move on to the next candidate after this one, all right? So this is your last case. One second, just want to make sure I've got the right image up for you. Right, I'm going to do these one by one. I'm going to show you this first one. Okay, so the patient presented with a lump on the right side of the neck.
Okay, sir. So I'm provided with the MRI images, corneal image. So this is the post-contrast study. A lump on which side?
The right side.
On the right side. So I'm looking on the right side first. So on this image, so are you changing the
I was trying to
thickness?
put it next to it, but it's not showing. I was trying to put them side by side, but I can't for some reason. So I'm just going to do this. And
So submandibular glands appears unremarkable. So parotid glands. So on the right side, there is the well circumscribed hypo-intense lesion, which is poorly enhancing, noted it is seen within the subcutaneous tissue and causing compression effect on the right parotid gland. It appears, it doesn't show any vivid enhancement. It is hypo-intense. I will see the rest of the images to see any
so I'll show you
lymphadenopathy
the,
and
okay, so I'll show you the T2. This is what it looks like on.
so it appears hyper intense on T2 weighted image.
Okay,
Uh,
and let me put
and
on
it is
T1 as well.
predominantly in the subcutaneous tissue and causing compression effect on the parotid gland. It appears hypo intense on.
This is T1. Hello? I can't hear you. Hello?
Enhancement.
Sorry, you broke up there. I didn't hear what you said.
Sir, it is a well-defined lesion in the right parotid. So can you hear me?
I can hear you now. So yeah,
Okay, sir.
well-defined lesion in the right parotid, and it's
Well-defined
high on
lesion which
T2.
Oh, okay. Hyperintense on the T1 weighted image and hyperintense on T2 weighted image, and it appears non-enhancing on the post-contrast corneal image. So it is likely a cystic lesion, which is seen in the subcutaneous tissue, causing compression effect on the parotid gland. It is not infiltrating the parotid gland. There is no local regional lymphadenopathy noted. So it appears benign lesion to me. I will
What do you think it might be?
correlate. It may be a sebaceous cyst in the subcutaneous tissue. It could be a simple epithelial epidermoid cyst. It is
Okay,
benign.
and how,
Hem-
yeah, exactly. So if you're thinking it's an epidermoid cyst, how would you find that out?
I will convey my findings. It is not an emergency, but I will convey my findings to the referring physician and recommend the external biopsy of this lesion.
Okay, from an imaging point of view, what would
Ultrasound.
help you put
Okay.
it more towards the epidermoid as opposed to a sebaceous cyst?
Different weighted images can help
Okay, I'm
to
going to show you the
differentiate the
diffusion weight.
epidermoid.
I'm going to show you the diffusion weighted images, okay? So this is the
So it is showing
DWI.
the different restriction. I will correlate with the ADC if it is hypointense on the ADC images. So it is low on ADC, so it is suggestive of epidermoid cyst. And
Okay.
it is not an emergency. I will convey my findings to the referring physician, and external biopsy or follow-up is recommended if patient is not symptomatic.
Okay. Excellent, excellent. This is exactly what I wanted to hear. The confidence with which you told me that this was a benign lesion is exactly what I wanted to hear. And you were also confident in telling me that this is not actually lying within the parotid, but in fact is lying within the subcutaneous tissue, pushing the parotid away, which isn't the easiest thing to tell. Even the consultant reported that struggled with that, but you were quite confident, so well done. I'm quite impressed.
Thank you,
I
sir.
will show you we'll just quickly go over cystic neck masses. Okay, so you mentioned that this wasn't an urgent finding. Very important to correlate this with any previous imaging, because if there is, and I think this is just as a general rule, I think it's always important to mention when you're trying to report back is that if there is any previous imaging, I would try and correlate with the current findings with. Okay, so always look at previous
Okay,
imaging.
yes,
It's
sir.
good to mention it. It makes it obvious to the examiner that you are thinking about previous imaging. Oftentimes we tend to ignore it, but it's good to mention it, I think. So
Yes,
correlate
sir.
with any previous imaging. And then with follow-up imaging, as you mentioned, it's a benign lesion. So it does need to be referred to ENT, and it does need to be discussed in the ENT MDM, because that's where we tend to decide whether this needs follow-up imaging or not.
Okay.
Or and we can reassure the ENT consultant that we think this is benign. Having said that, there is something that you guys need to be aware of. So I work for Sussex Trust. So this is our proposed pathway for cystic lesions. Obviously, history examination and ultrasound with a core biopsy most of the time rather than FNA of the fluid. It doesn't tend to get what we need. Most of the time, we just get blood with FNAs. It's a core biopsy if it's a cystic lesion, we try and aim for the wall of the cyst to get a positive biopsy result. If you try and get something from the middle, it's all fluid. So when you put it in the pot for collection, it's just going to dissolve in the liquid. All right. So
Okay.
when it comes to cysts,
Okay.
it's the wall that we're aiming for when we take a biopsy. That's an important point that you guys need to be aware of. We tend to worry more about cystic lesions, especially if they're in people more than or equal to 35 years of age. Okay. Um, Risk factors include something like previous, like a family history, um, or if they're a smoker. So they remain on the cystic pathway. We do an MRI neck, PET CT. If it looks benign, or mostly benign, then we tend to do a PET CT. If it's not showing uptake on PET, that means it's not metabolically active and it's unlikely to be malignant. Um, this is especially important when a core biopsy of a cystic lesion is unsuccessful. You have to remember that because cystic lesions do not have much solid tissue, there is a good possibility that the samples that you give them are going to be insufficient. And if that is the case, a lot of the time we end up doing a PET to see if there's any uptake. But you need to give it a few weeks after the biopsy, because if you've stabbed the neck to get a sample, then that's going to cause an increase in the PET uptake. Okay, so you need to give it a few weeks before you recommend the PET. Head and neck MDM discussion. So this was interesting. Incidence of malignancy in cystic neck mass is about 4 to 24%, but this increases. I mean, that's meant to say to 80% in patients more than 40 years of age. So that's quite a significant increase. I'm not sure how true this is. I actually personally couldn't find this anywhere. So whoever came up with this have said that there's a significantly high risk in patients more than 40. I don't know. I'm not sure about this. I couldn't find a paper on this. This is just a list that I've gotten off the. What I would recommend is any cystic lesion, if you come across one, you should mention clearly, yes, we think this is benign. Okay. And then
Okay, sir.
refer to the head and neck MDM, and over there, make it clear to the ENT surgeons we think this is benign, and then decide whether they want to watch and wait, in which case do a do an MRI in 3 months or 6 months. It doesn't matter. It's arbitrary. If you think it's benign, then 6 months is fine as well. Or do a biopsy for a definitive tissue diagnosis. And if if you still can't find a diagnosis, and the ENT surgeons, they can always do an excisional biopsy. But the main points are benign lesions still need to be discussed in the ENT MDM, and then we'll decide whether we need to do follow-up or a biopsy for a definitive tissue diagnosis. Okay? But you did really
Okay, sir.
well. You picked up on
Thank you,
everything.
sir.
Very impressed. Okay, so we're going to move
Thank
on
you, sir.
to case 11. Next candidate, well done.
Hello, sir.
Hello.
Okay.
And this is the slide that this is the slice that you need to look at, and what do you think is going on based on looking at that slide?
Okay, I've been provided with a single representative image of the CT scan of the
It's a CT scan of the neck, and it's a plain
CT
CT.
scan bone window, and I can see that there is evidence of a lytic lesion involving the chin of the mandible bone. Yes, yes.
Okay. This is a difficult case. I'm not gonna. So what I'm looking for here is you need to tell me whether what I'm about to show you, you think is something that is concerning, something that needs urgent referral or not. Okay? That's what I'm looking for here. I'm looking for how you're thinking about this. So
Okay, sir.
I'm
Okay,
going to
I've been
show you
provided.
coronal images if I can. Let me just see if this is scrollable, or maybe this one. No. Okay, I'll point to the areas. What are these? Can you see my cursor?
Yes, sir. These styloid processes bilaterally.
Right.
Yes,
Do
sir.
you think
And
these are normal?
they appears to be elongated, sir. Yes, so they might compress on the carotid arteries. So
Okay. They can also um, cause muscular pain,
yes, sir.
which can be worse on movement. But
Yes,
my question is this something that we should be concerned about? And what do we need to
sir.
do next?
So the elongated styloid processes, they might cause compression on the carotid arteries and may result in Eagle syndrome. So they are concerning features.
Do you think this is urgent?
No, sir, this is not an urgent finding, but would definitely need to inform to the referring
Okay. And who are the surgeons that this needs to go to?
head and neck surgeon, sir.
Okay, so that's ENT team.
Yes, sir, ENT.
And what is usually the treatment for this?
Surgical treatment is the treatment of choice, sir.
Okay, yeah. So definitive treatment is fine. Yeah, absolutely excellent. Yeah. So you've answered all the questions. It's not an urgent finding, but it is a significant finding, and a CTA is absolutely what we would do. And then it would go to ENT. If they can manage it with analgesia and maybe a bit of physio, sometimes that can work. If that doesn't work, then a treatment is a styloidectomy, which is a removal or shortening of the styloid processes to remove the
Yes.
symptoms. I'll just share the 1 second. So it's a rare it's a rare condition. Symptoms are multiple actually. It can cause sharp pain in the face, pain triggered by swallowing, turning the head, yawning, feeling of foreign object in the throat, dysphagia, otalgia, headaches, etc. Urgent finding you mentioned, no, but it's still a significant finding, and we need to rule out whether it's having any effect on the carotid artery. Okay, so
Yes, sir.
yeah, CTA is what we need. Usually we do it of the aortic arch. We don't have to do it up to the vertex. We can do it to the skull base. And then ENT referral and treatment is styloidectomy. So we've already covered all that. But
Yes.
yes, you got it. I think it was a particularly difficult case. It's a rare case. I wanted you to see it because it's a case that's come up in a candidate who was doing extremely well in the 2B, and then they just gave him a still. So a few of the
Yes.
cases that are something that have come up, it may seem a bit unfair because I think that was a bit difficult, but you picked up on it really well and you knew exactly what it was and you mentioned the treatment. So I'm quite impressed. So well done. But just be aware uh, of rare cases they might show you, and just be confident in what you think this is. Okay.
Yes, sir. Yes, sir.
All right. So we're gonna do the next case. Second. Right. So this is a patient who presented with left-sided sensory neural hearing loss. Okay. And ear pain.
Yes, sir. I've been provided with axial images of MRI brain. This or fiesta sequence images are there. Basically for cranial nerve examination. Uh, I will first see the stack of the images, then I'll start my observation. Yes, I can see that there is evidence of okay. I'll see all the images. Yes, there is presence of the uh, T2 iso to hypointense mass seen in the porous acousticus region, which is slightly protruding into the cisternal space as well, and inside the left-sided internal acoustic canal. The lesion is likely to be compressing the left 7 and 8 now complex. Yes, and the lesion is showing the narrow angle with the adjacent bones, and I would like to see the post contrast images to see the enhancement pattern in the lesion. However, the most likely diagnosis is the vestibular schwannoma, and the other differentials in the lesions present in this location are meningioma and the epidermoid or any other differentials.
Okay.
Sir,
Perfect.
I
Go on.
would report this finding and inform this finding to the referring doctor. It's not an urgent finding, however, significant finding, and would involve the neurosurgery MDT for further management of this lesion.
Okay. Excellent. Yeah, absolutely right. Covered uh, all of the bases. Just remember about 80% of the CPA masses are actually vestibular schwannomas. So it's quite
Yes.
in that area, this is the most common lesion. Other differentials are obviously a meningioma, but CPA, because this looks like an ice cream cone, which is a typical descriptor. So so if this was bilateral, what would you think? What would that trigger as a concern for you?
Neurofibromatosis is too, sir. It's
Okay,
syndromic
excellent.
assessment.
Well done. Well done. Okay, fine. So we're gonna move on. We got less than half an hour left, so I'm gonna move on to the next case.
Yes, sir.
You just need to move through these a bit quicker now. Um, okay, can you see the?
Yes, sir. Yes, sir. CT image, CT angiography images are
So I'm
visible.
gonna start from the top, and then I'm gonna move down. Right. Okay, so here we go. I've zoomed in now, so I'm gonna move a bit slowly, and then you tell me what you see. And
Yes, sir.
yeah, go on.
Now I'll start commenting. Sir, I can see that in the region of the tongue, I can see that there is hypo hypoenhancing central this hypoenhancing area with enhancing borders in the floor of the mouth. I think it's situated inferiorly to the tongue. In my routine practice, I would see the orthogonal images to confirm the location.
You got some coronal images.
Yes, sir, it's the well-defined and peripherally enhancing likely collection involving the floor of the mouth. It is extending superior to the mylohyoid muscle, and I don't see extension deeper to the mylohyoid. Yes, so uh, I'll ask whether the patient has any history of the fever or any pain while swallowing or
The
chewing.
patient has raised inflammatory markers and is pyrexial.
Okay, so these findings are likely to be representative of floor of mouth abscess, and I would inform this finding to the referring an ENT surgeon for drainage of this abscess.
Where do you think the abscess has appeared from? What is the most likely cause?
Sir, likely causes lymph nodal abscess due to infective lymph nodes or any tubercular node present.
Anything else?
Or any uh, tooth infection and caries tooth
Okay, yeah. So periodontal infections
dental
are the most
infection.
common cause of any collections that you see in the floor of mouth or in the cheek, etc., around the buccal cavity. All of these are most likely, the majority of the time, especially with a history of raised inflammatory markers and pyrexia, are due to a periodontal infection. So, okay. Do you think we'll be able to see a periodontal infection on this CT?
On bone window images, sir.
Okay,
Yes.
I'm gonna see if I can switch go to bone window images here. I think that'll do.
Yes, sir. On the left side, I can see that the mandible bone is showing some sclerosis, and around the root of the teeth, teeth I can see that there is loosened areas and there is cortical breach suggestive of the infection or the focus of infection.
Okay, so with the infection being, the collection being in the floor of the mouth, what are we concerned about? What's the biggest concern there?
This infection in the floor of mouth can spread along the spaces and may cause the vascular thrombosis or compromise in the neck spaces.
Okay, what can it do to the tongue itself?
In chronic, if it becomes chronic, then there is fibrosis, floor of mouth fibrosis can be there, sir.
Okay, what would be the treatment for this? What do we need to do?
Sir, the surgical drainage, sir, of this and antibiotics.
Okay, and referral to ENT.
Yes, I refer to the ENT.
Okay, so have you heard of Ludwig's angina?
Yes, sir, Ludwig's angina. Yes, yes, yes,
What
yes.
can you tell me about Ludwig's angina?
Sir, it's the infection seen in the diabetic patients, usually because of the periodontal infection, the spread of the abscess or infection along the floor of mouth, which in chronic state leads to fibrosis and fibrosis. Yes, sir.
Yeah, okay. So yeah, you're right. So this is a case of a periodontal infection which has resulted in a floor of mouth collection. This is an emergency for many reasons. If the collection spreads and go to the pre-visual space, danger space, it can go down to the mediastinum if it gets bad enough, okay? That will need IV antibiotics and wash out, essentially. Forget the IV antibiotics, wash out, definitely. Ludwig's angina is when you get a collection like this and it pushes the tongue back, compromising the airway. So it's dangerous because of that. Okay.
Yes, sir.
So it's an urgent finding, urgent referral to ENT. They need to try and wash that out as soon as they can. And obviously, in some cases, they even put tracheostomy so that the airway isn't lost.
Okay,
Yeah.
sir. Yes.
Um,
Yes.
so it's an emergency ENT referral. Need to treat that as soon as possible because the airway can be
Yes.
compromised and we can get spread of infection to the danger space. Okay. All
Yes,
right.
sir.
Well done. We're gonna do the next case quickly. That one, which one was that? That was case number 13. We're gonna go to 14. Where's it gone? Sorry, just bear with me 1 second. Just need to find it. Right. So this next patient is a patient who presented with a so it's a smoker, 50-year-old smoker with swelling that they've noticed on the left side where the parotid is, okay? We got the history. Can you hear me?
Yes, sir.
So 50-year-old presenting with a 50-year-old smoker presented with a 6-month history of left-sided parotid swelling.
Yes, sir. I've been provided with axial images of the MRI, T2-weighted MRI neck, going through the stack of the images first. Is in the right parotid region, I can see a well-defined T2 hyperintense cystic region with there is evidence of some T2 hypointensity fluid level seen within. There is no infiltration of this lesion in the adjacent parotid gland. However, it is causing mild mass effect on it. Uh, yes, sir. And on the left, in the left parotid, I can see that a T2 ISO 2 hypo, T2 wetted T2 isointense lesion, isointense to the skeletal muscle seen in the superficial lobe of parotid. And it is also well defined, and it's not infiltrating. However, the T2 isointensity uh, it's suggestive of it's a concerning feature. I would like to see the other post contrast images and T1 weighted images for further
Okay,
characterization.
I'll show you the T1 quickly first, okay? So this is the T1.
Yes. Okay. So the both the lesions are T1 ISO2 hyperintense to
Okay,
the
and I'm going to
T1 hyperintense
show you the
skeletal muscles. Yes.
post-con as well, post-contrast. Let me just, think it's too bright. Let me just, there you go. That's a little bit better. There you go.
So the lesion in the left parotid gland, it appears to be enhancing. However, I will see the subtraction imaging for better demonstration of the enhancement, as the lesion was already hyperintense on T1 as well. The right-sided lesion is not that hyperintense.
Okay, okay, that's fine. So you've just you found the two lesions. I'm going to tell you that there's no cervical lymphadenopathy. What I want you to tell me now is, given the history and the imaging findings, do you think this is a benign lesion or a malignant lesion?
The imaging finding
And
wise,
what would you do next?
the lesion is well defined. However, the in a smoker, the parotid pleomorphic adenoma, they appear benign, but they have malignant potential as well. So I would refer this patient to ENT surgeon for further management and uh, excision of this lesion.
Okay, prior to excision, can we do anything else to confirm that this is a...
So we can do FNSC or a biopsy of this lesion for histopathology.
Okay, fine. So you're right. This is... So the differentials, so the, two lesions, one of them on the right in particular is cystic. I'll bring the T2 up to make this a bit clearer. Yeah, whereas the one on the left, there isn't much cystic change going on in there, or it doesn't appear that
Yes,
way. It's low T2, which can be due to a number of things, okay? Could be due to hemorrhage as well, that it's becoming low T2 and high T1. Yeah, so it could be cystic with hemorrhage in it, who knows? But the right one is definitely cystic with some debris, which you can see in the dependent regions. Now, the reason why I mentioned smoker in the clinical history was because Warthin's tumor, which is a benign tumor, is something that occurs more commonly in smokers, and it's usually bilateral, as
yes,
opposed to a pleomorphic adenoma, which is more common than a Warthin's in
yes, sir.
general, but less common in smokers.
Okay, yes,
Yeah, so Warthin's tumor and a so Warthin's tumor are also more cystic, most usually, than pleomorphic adenomas. So your differential should be a Warthin's tumor or a pleomorphic adenoma.
yes, sir.
No definitive way to say that it's one or the other without doing a image guided biopsy, usually an ultrasound guided core biopsy. Okay. And we tend to
Yes,
biopsy both of them, not just one, because it could be that we have a Warthin's on one side and pleomorphic adenoma on the other. There's no definitive way of saying. Okay.
yes, sir.
And the cure of, I mean, if it turns out to be Warthin's, which is a completely benign lesion, we tend to actually leave these. We only consider excision if you're having facial nerve symptoms. So anything that is, so the retromandibular vein runs behind the mandible. So you can see the cursor. I don't know if you can see the cursor on the screen, but this is the
Yes, sir.
mandible, and behind it runs the retromandibular vein, which is, you can see on the here, is being a bit compressed. So the facial nerve runs right adjacent to the retromandibular vein. And if you've got a lesion going to the retromandibular region, encroaching the retromandibular vein, there's a good chance that the facial nerve is also being affected. So they need to correlate that clinically. And if they're having those symptoms, then it's a discussion. Then the surgeons need to decide whether they want to excise this or whether they want to follow this up, because obviously surgery has a risk to the facial nerve as well.
Okay.
Just remember, deeper lesions. So whether something is in the superficial lobe or the deep lobe of the parotid is also determined about whether it crosses the retromandibular space. So anything lateral to the retromandibular space here, so I'll draw a line here so you guys can see, just so you know. So this space, anything medial is the deep space, anything lateral is a superficial space, okay? So this is a superficial and a deep lesion, whereas the one on the left is completely superficial. Does that make sense? So
Yes, sir.
just be aware of these findings. It's important to mention, if you find a lesion or you see something there and it's going into the retromandibular space and you think the retromandibular vein is compromised, you can mention in your 2B that, the facial nerve runs in that region and there's a good chance that it might be compromised by the lesion, so clinical correlation is advised. Stuff like that. It's just a bit of information that goes beyond the core curriculum, or it might even be in the core curriculum, but it would be good to mention. Okay.
Yes.
But yeah, this is a lesion that needs to be referred to ENT. It's likely a benign Watkins tumor, but we need to do a core biopsy to confirm it. And then based on the result, we decide whether we want to excise this or do nothing. Okay.
Yes, sir.
All right. So that was one more case for you, I think.
Yeah.
Is it? No, I think is it one more case? How many cases we done for
4
you?
cases, sir.
Okay, we'll do one more. Okay. Right. So this one, I think we might overrun the session a bit. I'm going to be as quick as possible. If I can just bring it up. Can you see the images?
Yes, sir.
Okay. So what do you see?
I've been provided with contrast enhanced scan of axial CT scan of the neck. I can see that there is a large mass which is involving large lobulated mass which is seen involving the laryngeal region. It's more predominantly on the left side and it's pushing the trachea towards the right. I'll see its superior and inferior extension. I'm looking for the organ of origin on the left side.
Okay, so you can see a large, so I'm going to speed
Yes,
up
sir.
the case a bit. Okay, so you find there's
Yes,
an
sir.
abnormality. It's very hard to miss. So there's a big mass in
Yes, sir.
it appears to be arising from the thyroid. Thyroid sits around this region, primarily on the left-hand side. Okay, so here
Yes,
are the
sir.
lung windows.
Sir, the lung window, I'm looking for any metastatic lesion in the lung parenchyma. Uh,
Did you see
uh,
any?
uh, in the images which I can say I didn't see any metastatic images, but I think the middle images were skipped.
Oh, okay.
Uh,
How about, can you see?
Sir, apical segment of the right lobe, I can see the ground glass density like rounded lesion.
Okay, I'm gonna move on through to the other. What
Um,
about?
Yes, one more lesion is seen in the superior segment of the right lower lobe, sir.
Okay, and there's one in the right there.
One medial segment of right middle lobe.
Right, and then I'm gonna bring the soft tissue windows up again, and then I'm gonna quickly scroll down. Anything else you see?
Uh, there is mass lesions likely arising from the head region of the pancreas, sir.
Okay, looking at all of these findings, what do you think is going on and what would you do next?
So, the thyroid malignancy, the pancreatic malignancy, I would like to examine this patient for the MEN syndrome, sir.
Okay, do we think it's a thyroid malignancy or could it be something else? Remember, I'm asking you, thyroid malignancy is one possibility,
Yes, sir.
but the thing you need to remember, when thyroid cancer metastasizes, you get multiple, lots of them, well-rounded, hyperdense nodules throughout the lung. These ones are a
Yes,
bit more bizarre. These are a bit more ground glassy and a bit more spread out. Okay.
yes,
And then it's
yes.
unusual for thyroid tissue to metastasize to the pancreas. So fine, thyroid is one possibility. What other possibility is there, and what do you need to do to confirm the diagnosis?
The USG guided biopsy of the lesion will provide us the diagnosis, sir.
Yep. Okay. And what was the other differential? You didn't mention the other differential you think this could be.
Sorry, sir, I'm not thinking
So
in
I'm going to give you a tip. I'm going to give this tip to all the trainees. Okay. So any destructive lesion, or any lesion that metastasizes, or any kind of metastasis that you see, one of the sure shot ways, if you can't think of differential, is lymphoma. Okay. Lymphoma, TB, sarcoid, these are things that can present as anything, but lymphoma generally is something that you need to consider, especially if there's any sign of lymphadenopathy, whether it's diffuse or a little bit with metastases. Okay, so the differential for this was a lymphoma. We did a biopsy of one of the nodes in the neck, turned out to be a lymphoma because it's very unusual for thyroid cancer to be present in the pancreas, and the appearance of the lesions in the lungs were unusual. Anaplastic thyroid is as aggressive as what you saw on these images, which we mentioned earlier as one of the aggressive types, but extremely rare. But again, just like at the thyroid tissue, you'd expect a specific way it looks like, and lots of hyperdense nodules in the lungs, as opposed to these ground glass, bizarre kind of appearing in which is unusual for metastatic thyroid cancer. Okay, so yes, biopsy and then MDT discussion, and then treat it accordingly based on what the biopsy results show. Okay, so
Yes,
sorry I had to rush through that. I'll quickly go on to the next case. Who's the next candidate?
Hello, hi.
Hello, hello, hello. Sorry, I know it's a bit late in the day, but I'll try and
It's
go
okay.
through the cases with you. So just bear with me while I bring up the
Yeah,
case.
sure.
Okay,
Yeah.
so this is a patient who presents with recurrent submandibular pain bilaterally.
Recurrence of
Okay,
okay, so I'm presented with axial T2 cuts of the neck. I'll just go through the images before submitting my findings for a patient presenting with recurrent bilateral submandibular pain. Um, okay, this is T2 axial still there seems yeah, okay. The left both submandibular glands are slightly hypointent. The left submandibular gland shows I'll focus on the submandibular area since this is a complaint. So both submandibular glands appear slightly heterogeneous with areas of hyperintensity, more on the left side. There seems and there seems here, yeah, there seems to be extrusion at the floor of the mouse. I mean, I can see the geniohyoid muscles, and lateral to them, there seems to be extrusion of some tissue. Yeah, this one, yeah. I'm just trying to, and this, so bilaterally. And this is at the floor of the mouse. At the floor of the mouse contain the sublingual gland and maybe also the submandibular and the submandibular duct. So trying to put the findings together. With the I want to visualize these are the submandibular glands, right? Yeah. So
Yes. Yeah.
bilateral
Okay.
heterogeneous submandibular bilateral heterogeneous submandibular gland with foci of hyperintensity and abnormal lesions at the floor of the mouth that protruding beyond the floor of the mouth. I can think of so it's either something that affects both the submandibular gland and the sublingual glands, or maybe stones that led to ductasia and inflammation of both submandibular gland. However, I would like to see the stir, the T2 fat sat, to better appreciate if there is any related fluid collections or dilatation. The dilatation of the duct is better seen on maybe ultrasound, and if there is stones or signal voids, I cannot appreciate any stones or honestly any dilated duct because the duct will it's not the course.
Okay. So what do you think? So what do we need to do next? What do you think is going on, and what do we need to do next? Go summarize it, please.
Okay, there sounds to be inflammation of both submandibular glands. It's just,
I'll go down to them. Yeah, you look, you're not wrong.
yeah. Yeah, I'm trying to trace if this is the duct and follow it to the submandibular gland. However, because I'm not scrolling, so I cannot. But I'm just trying to figure if this is really a dilated ectatic duct reaching through the gland, and if there is any
Okay,
signal
so this is the duct. This high
Yeah,
T2 signal on the
yeah,
left-hand side is the duct, and
yeah.
this high signal on the right is
So yeah,
also the duct. So as I come along here, this is the
yeah,
duct,
they are
and this
ectatic.
is the
They show
duct.
because because I'm not really scrolling, so they show bilaterally ectatic ducts all through from the floor of the mouth till the submandibular gland. I cannot really appreciate any signal voids within the duct to see the stones. However, they will be better seen on CT. So the two possibilities I'm thinking of is bilateral stones of the duct with consequent back pressure change, dilated duct, and inflammation, cyanoidinitis, inflammation of both glands. However, I would like to see the stir for any to better visualize the inflammation and the edema. The ultrasound also will show the CT will show the fibrilli, and I think this protrusion may be like the ectatic duct may have been ruptured, like it has a name, maybe a rupture because of the obstruction. Okay,
So who do we need to refer to? And is this an emergency?
I convey these findings to the ENT. There is an option of MRI scilography. I don't know if there is MRI scilography that better visualize the duct, or we can do the scielogram, the scielogram to
Okay.
visualize the duct, and I will convey the findings to the ENT to be discuss the case and for further treatment.
Okay, perfect. Okay, so excellent. So you picked up on all the abnormalities, and I just want you to be a bit more confident what you think is going on. So you're right. You're not scrolling, so that makes things harder. So I'm going to quickly summarize. This patient had recurrent silodinitis. They got dilated ducts, and it's most likely due to this. Have you heard of a Boutonnière's deformity? So this muscle here, you can see on this either side. This is the mylohyoid muscle. So you get sublingual glands sticking out of the mylohyoid muscle. And because the submandibular duct goes through this region as well, it can get compressed due to this deformity. So that's one cause of the recurrent silodinitis, but we can't exclude small stones or a stricture, just a general stricture that can happen due to recurrent infections. All right. So yes, a xylogram is the first thing that we would do. But the most likely cause is that, and it's not an emergency, it's because the patient's had these symptoms for a while, they're just having recurrent silodenitis. So we would do a sialogram, refer to ENT, and if there is a stone, if it's 7 millimeters or less, they normally pass. If they're larger than that, they usually require some kind of surgical intervention to have them removed. Okay. Or if it's the mylohide that's causing it, that would also need surgical fixation, so it would stop the recurrent silodenitis. Okay. So that's good. Good, good, good. We're quickly going to move on to the next case. Going to try and finish the next 5 minutes. Sorry, this is overrunning. Okay. Oh, come on. 1 second. This is taking a while.
Okay.
So the next case is a patient who had a tumor removed from the right cerebral hemisphere, and post-op um, they were fine for a few days, but now they've started to deteriorate. Okay, so I'm going to bring up the post-con. There we go. Can you see the images?
Yeah.
I'm going to quickly scroll to the relevant area. Okay, and then you can tell me what you think is going on. Oh, this is not covering the relevant area.
He had a tumor removed from the right cerebral hemisphere, right?
Yeah, I'm just trying to. This is the same case that I put on earlier. This is not the right case.
Yeah.
Yeah, here we go. Sorry. Here we go. Here's the case.
Okay.
Okay, I don't know why it's not loading the case. Yeah, here we go. Okay, so can you see? Can you see the
So
case now? There we go.
yeah, sure, I can. So I'm presented with a post-contrast T1 axial cuts of the brain for the post-operative patient. I can first thing I can see is the enhancement pin at the at the high right frontal region with related effacement of the sulci. There also seems to be leptomeningeal enhancement, leptomeningeal and slight thin pachymeningeal enhancement at the area of concern at the right upper with effacement of the sulci, and of course the post-operative change in the form of the craniotomy flap and there is a like tube hole seen. So I'm just checking because this ring enhancing lesion with the related effacement of the sulci may lead to brain edema, and the leptomeningeal enhancement may lead to brain edema. So I want to exclude herniation, any evidence of brain herniation. There doesn't seem to be any brain herniation and normal foramen magnum. There is no hydrocephalus, and maybe just the right lateral ventricle is effaced because of the edema. So this may be, given the post-operative history, it may be a residual, or it may be an abscess post-operative infection, especially with the leptomeningeal enhancement. It may be meningitis with intracerebral abscess. So I would like to check the diffusion weighted images to confirm if this is an abscess or no.
There is diffusion restriction.
There is diffusion restriction. So if given ring enhancement and central diffusion restriction, this will confirm the post-operative infection of meningitis, leptomeningeal enhancement, and intraparenchymal abscess with effacement of the apsilateral sulci and lateral ventricle. However, there is no herniation. However, this is an urgent finding. I should immediately convey the findings to the referring physician and the neurosurgery, maybe for them to proceed, maybe evacuation of the abscess or immediate intravenous antibiotics.
Maybe or definitely.
Definitely, yeah. Just about the treatment, they will remove the abscess, drainage of the abscess.
They have to wash out because you've got meningitis. Half the brain is showing leptomeningeal enhancement. So yeah, You're absolutely right. Picked up on all the findings, found the enhancement. You asked about the right questions about diffusion restriction. Excellent, excellent. Try not to repeat yourself, because when you were giving me the conclusion again, you mentioned the leptomeningeal enhancement, you mentioned the diffusion
Yeah.
restriction again. You've already mentioned all that. Just
Okay.
tell me, yes, there appears to be post-op collection with meningitis. This will need neurosurgical referral with likely washout.
Okay.
Urgent finding. Okay, well done. Excellent. Okay, so move on to the next case. Um,
Mhm.
can you see the images?
Yeah. Yeah.
So it's a 16-year-old with learning difficulties, and they
Learning.
have got
Yeah. Learning.
pain in their parotid glands.
Okay. They have learning difficulty to learn.
Learning
Learning,
difficulties.
yeah. Okay, so I'm presented with axial cuts of T2 sequence of the neck. I can immediately we scroll through the images, then convey the findings. Is this
So this is all you need, really. What do
yeah,
you see
okay.
and what do you
Okay,
think?
so at the area of interest, bilateral parotid glands show multiple minute cystic lesions, not really replacing still the whole parenchyma. In a 16, there is slight atrophy of the thyroid of the sorry, I'm talking with the parotid of the parotid. I cannot see the deep lobe. However, bilateral subcentimetric cystic lesions involving both parotid glands. I'm just the differential in this appearance is usually between maybe HIV related, the lymphoepithelial, not maybe it's HIV related, or Sjogren, but given the age 15 years,
16. Yeah, 15, 16.
16, yeah, bilateral cysts of the parotid. I mean, I know Sjogren and HIV, but the learning difficulties and 16 years old. Uh,
Okay,
mm,
you're not wrong. Okay,
yeah,
so I'm gonna stop you there for a second. You're absolutely right. Sjogren's is a primary differential, is a
yeah,
primary diagnosis,
yeah.
but there are differentials. What do you think
Yeah.
this is? This area here?
It's the clivus. No?
No, this area here that the cursor is going over. What do
Yeah,
you think
yeah,
that
yeah.
is?
Oh, yeah, 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 yeah. This is the nasopharynx. Yeah. Oh my God. Yeah,
Yes,
yeah.
it's the
This
posterior
is the
nasopharynx.
yeah the
So the
nasopharynx.
lymphoid
So
tissue, what do you think of the
yeah, yeah,
lymphoid tissue in the
adenoids. Yeah, yeah.
posterior?
There is yeah. There is T2 isoto hyperintensity symmetrically involving the nasopharyngeal airway at the anatomical site of the adenoid. So this is likely enlarged adenoid or enlarged lymphoid tissue. So enlarged lymphoid tissue together with the bilateral cyst of the parotid is suggestive of lymphoepithelial disease. It can be lymphoepithelial disease or lymphoproliferative disease. So it's likely lymphoproliferative disease. It can give this finding in the parotid and the adenoids.
Yeah, it
Uh,
could be. It could be lymphoma. You also get
yeah,
something called benign lymphoid hyperplasia, but this seems a bit too much.
yeah,
I've seen it before, but this seems like a lot. So you can't include a lymphoproliferative disorder. So what would you do? It would be ENT referral, and they'd maybe scope the patient and take a sample of this lymphoid tissue to exclude
yeah,
lymphoma.
yeah. And it's
Okay.
it's only encroaching
And they
upon the
also need to do
airway, and that's why
anti-ro
it's
and
likely
yeah,
causing
so
learning difficulties in large adenoids. Yeah,
yeah, and they also need to do anti-ro, anti-La antibodies to and do tests to make sure that there isn't Sjogren's as well. So those are the two differentials that we need to rule out in this one. Okay. Good. And then we're gonna do what case are we on? This is the last case, the next one, okay?
okay.
You've done extremely well, actually. Very impressive. I'm really happy with everything you've done so far. So this is the last one. So this is a patient who's presented with right-sided limb weakness, okay?
One-sided lymph weakness. Okay. Okay, so I'm presented
So
with
I'm
an
going to start from the top and
yeah,
then move down slowly, okay?
I'm presented with plain cuts of axial CT brain for a patient complaining of right-sided limb weakness. The first thing I can see is the loss of the of the gray-white matter differentiation of the high left frontal cortical and subcortical hypodensity with loss of the gray-white matter differentiation of the left high frontal region. I'm just going through the cuts to exclude any other finding. I cannot detect any other striking findings. The vessels, the visualized vessels appear maybe slightly hyperdense, but there is no asymmetry. Yeah, and there is a sizable lesion seen involving the right side of the maxillary, the right side of the maxillary, the right maxillary sinus, as well as the temporomandibular joint. It is and the whole bones actually. Okay, so there is a lytic.
So I'm sorry, I'm showing you this just to speed up the process, but you picked up
Yeah,
on
yeah.
it.
Okay,
So
yeah. There is a lytic
you've no,
region
so the
involved.
right-sided weakness is explained by what? What's that explained by?
The right siding maybe because of the upper left hypodensity. It's there is left upper hypodensity. Yeah, here. This
Yeah. So
yeah.
this is what
So
territory?
this is the ACA territory. So I was
Yeah. So
trying to
what would
see
we
if there
do?
is any
What would we do?
hyperdense
What would
for
we
this.
do for that?
We can CT angio to check for the ACA.
Okay.
For
CT
the vessel,
angio from
CT
where to
angio.
where?
From the base of from the arch from the neck till the brain.
Yes, to the arch of the circle
Brain
of
is gone
Willis.
from the arch of the aorta from the neck till the brain.
Yes. Okay. So you always say from the arch to the circle of Willis or the
Yeah.
vertex or whatever. But mention that. And then this thing, which you found incidentally as we were scrolling through.
Yeah, there is diffuse replacement of the facial bones with the appearance of like ground glass appearance. Yeah, it seems like a ground involving all this, but it's the weird thing is the age of the. Okay, so there is diffuse involvement of lytic region of the facial bones as well as the skull base and the right ramus of the mandible. It has mixed sclerotic lytic densities with areas of destruction. I would like to know the age of the patient. If he's an old patient, this may be Paget
Old
disease.
patient.
Old patient, this may be Paget disease, and I'm concerned about malignant transformation because there seems to be cortical interruption and destruction, so it can cause malignant transformation. The other differential, if it was long-standing, like from him at a young age, it may be fibrous dysplasia, and also I am concerned of the malignant transformation, especially at the right maxillary sinus area.
Okay. Right. So the right maxillary sinus has also got all this opacification.
Yeah,
Okay.
yeah. This obviously, yeah.
And you've got some bubbly secretions on the left-hand
Yeah, so
side.
acute on top, yeah, acute on top of chronic sinusitis.
Can that cause bony destruction?
The sinusitis, acute on top of chronic, not I mean, if it is
Sinusitis in general, so chronic sinusitis, recurrent sinusitis, can it cause bony erosion, thinning, destruction?
if it is long-standing not like avid bone destruction. However, it can cause thinning and like slight resorption of the bones if it is long-standing, like in polyposis. It is sinusitis because of polyposis, but not that manifested bone destruction. I mean, the anterior border of the maxillary sinus seems really destructed with intra maxillary speckles of bones. So it seems like aggressive destruction.
Okay, so there was a CT done 10 years ago, which is exactly the same.
Okay, so since it is the same, it's likely a benign, a long-standing process. So yeah, affecting multiple bones. So it's likely Paget disease or fibrous dysplasia. Yeah.
Yeah, so the ground glass changes here. I mean, your
Yes.
differentials are spot on. So ground glass change is more suggestive of fibrous
Fibrous
dysplasia
dysplasia. Yeah.
and unchanged. So when you get chronic sinusitis, it can cause bony wall thickening, or of the sinus that's affected.
Yeah.
But it can also, if you get recurrent acute on chronic, it can cause bony thinning and some areas destructive appearances.
Yeah.
Okay, especially in a patient with background fibrosis. So these areas,
Yeah.
these are due to superadded chronic sinusitis on a background of long-standing fibrous dysplasia.
Okay.
So, well, so management-wise, for fibrous dysplasia, do
Yes.
we need to do anything drastic?
No, fibrous dysplasia is not an urgent finding. However, he may need follow-up because of the risk of malignant transformation. And if he's complaining because of the bony affection, if it is like near the skull base, compressing any vessel or a vital nerve, and the patient is complaining, he may be referred to the ENT for adequate management. However, in this case, the urgent finding is the left upper suspected infarction, which will need an urgent CT angiography to see the vessels. And right at this CT, there is no signs of herniation or there's no signs of herniation or crowding at the foramen magnum. So there is like
Okay.
nothing.
Okay, I need you to stop for a second. You've covered
Yeah.
everything. You mentioned everything. So
Okay.
when you're summarizing, you've already said everything. You've said they've got left ACA infarct, which is causing the right-sided weakness, acute infarct, might I add. Therefore, you need to do a CTA and urgently refer to the stroke team. Yeah?
Yeah.
Fair
Yeah.
enough. And, we can get neuro IR involved as well based on whatever findings we get.
Yeah.
And then you got the incidental finding of fibrous dysplasia, which is long-standing and doesn't require any current management. That's all you need to say. You don't need to add anything else when you're summarizing the statement. So stuff like you mentioned, cerebellar herniation, all of that stuff, that's in your initial statement.
Yeah.
When you're summarizing, I just want you to tell me about what needs to be done immediately. This is the main problem. For instance, if somebody has a left MCA malignant infarct, all you need to tell me is a left MCA malignant infarct, and we need urgent referral to this as your summarizing statement, rather than repeating everything you've already told me
Yeah.
in when you're describing what you've seen in the findings.
Yeah.
Okay, but excellent. I mean, I'm very happy. Well done.
Yeah.
Very
Thank you.
impressive.
Thank you.
Okay, guys. So those are all the cases for today. Because we already overrun a bit. So that's about 20 cases we've done so far. Please do, if you've got any questions, feel free to ask them now. And please do remember to fill in the feedback form, okay? And I promise next time when I give a teaching session, I'll try and keep it a bit more in check. I'm just not very used to using this software that we're using today. Okay. Oh. No questions? So there's a question here. Was it a subarachnoid hemorrhage in the hemorrhagic Mets case? To be honest with you, I don't know. And in the it doesn't matter. Okay, you can say there may be. It's not important. The important thing is there's a Met and how you're going to manage that. That's what they're testing you in the 2B. There might be a slight subarachnoid along the anterior sulcal space. Another question was about thyroid. Red flag raised for even hyperechoic lesion. Yes, even for hyperechoic. So if it's hyperechoic compared to normal thyroid tissue, that can sometimes be seen in papillary thyroid cancer. So that is something that needs that as well. Okay. And then where is it? What's the direct dissection case? Yeah, I can put that up for you guys. Oh, and someone quickly, I'll answer. So somebody mentioned, how do you differentiate between fibrodysplasia from Paget's? So one of the things is the ground glass appearance is less common in Paget's. You get more trabeculation in Paget's than you do in fibrous dysplasia. And the bony expansion is more in Paget's than it is in fibrous dysplasia. And there is also the places where they occur most commonly varies as well. Like Paget's can be in the pelvis more often, whereas fibrous dysplasia is more polyostotic than monostotic. So ground glass opacification, more in fibrous dysplasia and polyostotic, whereas Paget's is more trabecular, more expansion, and in pelvis and certain areas more common than fibrous dysplasia. I hope that answers that question. But the dissection one, I'll quickly put up again for whoever's interested. Any particular question about the dissection one? Somebody's mentioned in the thyroiditis case, was it okay not to have to say what type of thyroiditis that was? Yeah, it's okay not to say. You can give different causes of thyroiditis. Just sticking with autoimmune, if it's a female, then Graves' disease is something to consider. But the important thing there we're testing is, do you think this is something that's malignant, or do you think this is something that can be managed more conservatively? We are thinking about the way that you're thinking based on the imaging findings over time. Where is it? Slide 2 and 3. Let me just bring that up. Bear with me. So case 2 and 3, I think you mean by slide rather than slide 2 and 3. So autosclerosis is this. Okay. And case 3 was the intracranial space occupying lesion. I haven't put down the exact management there, but we had a general discussion about this, okay? And then the last thing you guys mentioned was you need case 1 and 2. Okay. Let me bring that up. Case 1 was this. Okay. And this was a bit of information about autosclerosis and then the management. Okay. And then somebody asked, they wanted to see the case about aortic dissection, which let me just see which case that was. I think that was case. What case is it? Case 9. I'll bring that up 1 second. So if anybody wanted to see that, somebody mentioned it in the chat. There you go. If you guys can see that. So this is the internal carotid. So you've got this like a fried egg appearance. So you got the yolk in the middle with a high signal surrounding it. These are usually on fat saturated sequences. That's the best. So if they ask you what sequence would you like to look at, if you're concerned about dissection, you need to mention fat saturated sequences, okay? T1 fat sat primarily. Okay, but any fat sat will do. And then this is the vertebral artery dissection. Okay, on the right. Right, any other questions, guys? Or is that it? Oh, you can't see the case. Oh, why not? I am sharing the screen with you guys. Let me try doing that again. Can you see now? So, okay, so this is, so T1 fat is the ideal sequence for any fat saturated sequence to do. That's the common carotid. Sorry, that's the ICA, internal carotid artery on the right hand side with the well, I call it a fried egg appearance, but you can call it the crescent sign as well, where you've got the high signal going around the ICA, and you've got similar thing going on with the vertebral artery on the right hand side, just there. Okay, and the slide I'll put back up quickly because I know you guys have to go now. It's nearly 9 o'clock.